I've been involved with long COVID kids since my daughter Rosie became ill in 2021. And she's got, with the help of Dr. Trinick and Dr. Kane, has got from the point where she couldn't stand up without collapsing to now coming towards the end of her first year in a degree in art college. So with support, belief, and appropriate treatment for things that can be treated, things can get better. And there's a lot of hope here, which is the name of the charity as well, which is great. And I will come to a question, I promise. There's lots of things that Dr. Trinick mentioned that are helpful. LDN, right? We can get that. Pretty much anyone can get that, actually, because you can get the LDN Research Trust. That helps. Pabrinex infusions we can't get. We know that they worked for Rosie. She had them. So what do? There's nowhere to go. The health minister promised us in January last year, promised Rosie that there would be a regional clinic for post-viral conditions that would treat children and adults. And this is the bit that brings me to the question. I'm just going to read the letter that we recently had. We emailed asking what was happening. Right, dear Colin and Rosie, following your email to the Health Minister on the 20th of February, I've been asked to respond on his behalf. Unfortunately, there has been a delay to the launch of the Regional Post-Acute Infection Service, which was due in the autumn. The intention was to expand post-COVID services to include people with other post-acute infection conditions, given the similarities of blah, 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 blah. Right, this is the bit. SPPG, Strategic Planning Group or something within the Department of Health, has been unable to secure a trust willing to act as a regional host for the service. Until this is resolved, patients can continue to be referred to the existing services established for long COVID assessment. I hope this is helpful. Please do not hesitate to contact me if you require any further information.
I think what you said there first was right.
Yeah. So in the face of that, we know that there's things that Benita set out in the model for what can work. We know some treatments that can work. What the hell do we do in the face of a system that will not respond even when we beg them? That's my question, I suppose.
Well, I think the question you raise is a common question. And I would say that there's a lot of things that are in the pipeline for development. I can't tell you what tips each one into success or keeps each one back exactly. But I think I have a lot of time for our public health consultants and experts. They have a tough job, but the ones that I've worked with have always been very fair-minded and very straightforward. Now, so it's not a quick process, but therein, if they make a strong recommendation, then that is likely to carry quite a lot of weight. I'm disappointed to hear that there isn't a trust that would do it. I don't really understand why. I suppose we'd need more specifics on that one to get a bit of insight. The trusts are pushed, but they're always pushed. They've always been pushed. They do manage to do some things and not other things. So I think it's a matter of not giving up, and I'm sure you don't, but not giving up, finding the right people, pressing the right buttons, and so on and so forth. And I would think when it comes to it, people power, the power of you in this room and the rest of the hope for ME couldn't make it. I'm sure I don't know exactly how large it is, Linda, but it's quite a lot of people, and that going through your public representatives and using any and everything you can use will eventually win through. It takes longer and it's frustrating, but that would be my best answer.
Yeah, thanks for the question, Colin. I think I can sense the frustration in this. Has been a long process for you guys. You've advocated hard for years. I mean, I think as someone who, in my NHS role, in the latter parts of my training, I did a master's in healthcare leadership, and a lot of my roles in the NHS were around systems leadership and trying to bring different parts of the systems together. And it was hard before the pandemic, but I think since the pandemic and all the challenges it's given the NHS is completely overwhelmed with all the stuff they should be doing already. So just trying to get waiting list down, it's a year to see a neurologist, a year to see someone in ENT. It's just desperate, the state of outpatients. So I think these trusts, the idea and the thought of taking on something completely new, which seems really hard and complex, and by the way, we haven't got any specialists, they don't want to touch it with a barge pole. You can sort of understand that in some ways. So these services always develop because there is some zealot champion who pushes things forward from within the system. And the problem is all of us who are interested in this world have been forced to leave the system. So you've got people like Willie for years has been pushing from the outside. Now I was sort of on the inside trying to do it, got completely unsupported, left. And so you end up in this kind of catch-22 where the people who can really push things forward end up leaving to do the work. So we have to bridge that gap somehow, making some progress in England that actually NHS England are talking to me and they're listening to a degree. But we've got to bridge that gap. We've got to bring in all the experts who know about and understand this stuff and work together. We can do that. And then we can influence the trust. So from a leadership perspective, we've got to keep going to the top and the top and the top, and to government, to the Royal Colleges, and gather momentum, because I don't think there's any trust that's just going to suddenly take this on without all of that work being done as well. Not easy, takes time.
Can I just say that on an individual level, my experience with most of the patients I've seen is that the one thing which really makes a difference is the expansion of their blood volume. And one can actually achieve that by getting them admitted to hospital under sympathetic consultants. And that therein lies the problem. I've had a number of patients whom I have actually managed to get into hospital, put into a nice quiet side room, and advised 2-3 litres of normal saline on a daily basis. Incidentally, the normal saline should be warmed to body temperature to avoid any temperature gradients that might occur, which could trigger the mast cells in the patient's vasculature. And it is something as simple as that, which will actually help improve the outlook of patients very considerably. And all I can do at the moment is actually say I have an experience of 1 or 2 patients for whom that's happened. But the NHS surely has got the facilities to provide that service for more than the few patients I've seen.
May I say just briefly, Willie, have you any experience of diarrhea? Because when we talk about intravenous fluids, it requires a cannula and this and that. And so I've forgotten how I came across it, but I've known about diarrhea for a long time, but I came across it as being a sort of an oral method of doing the same thing. Is that rubbish or does that work?
No, diarrhea is very helpful in that the combination of glucose and electrolyte that you get with diarrhea actually promotes the absorption of the water in which they're dissolved. Problem, you can actually expand your blood volume maybe over a space of 2 hours, but then that volume have actually increased, you've increased your blood by, soon gets lost in the urine. And really the important thing to do is to investigate the pituitary gland, see what's missing, and replace the missing hormones.
I think we did have a service in York that was doing that Sanjay Gupta led, and he had patients coming in weekly for IV saline, and they shut it down because they said, well, it's not commissioned, and there was uproar from the patients, but they said, we need it for something else. And this is the problem, unless it's the systems mandating it and saying we have to do it, it'll just get bumped for urgent care, which is what is always prioritised in hospitals. So these ad hoc sort of admissions, it just relies on the goodwill of the person in the hospital. And we really got to move away from that into structures that support treatments, which properly paid for, commissioned, resourced. And therein lies the sort of the difficult, wicked problem. But we will get there one day, I'm sure of it. I'm sure of it.
My question is two-pronged. What's the correlation between long COVID, which is relatively new, obviously, and ME, or chronic fatigue, as it's now better known as? And basically, there was a lot tonight talked about genetics. Is it, if genetic was applying to ME, and is it the same reason, and why, and how could it be the same with long COVID, which is it more a viral strain? That's something I really was interested to hear tonight. Thank you.
Who would like to start?
I think, to give you the simple answer, in my view, long COVID is simply ME triggered by COVID infection. And there are very, very few differences to be identified between people who've had the label long COVID applied to them and someone with the longer standing ME. If there is any difference at all, some long COVID patients do seem to have a tendency to produce micro blood clots, which would appear to be generated initially by the COVID infection. But that's the only difference I can even begin to identify between long COVID and ME.
Thanks. I'd agree with that, Willie. I think one of the other challenges we have with the term long COVID is it's a bit of a catch-all. So people use it for probably 3 different groups of patients. So the first group is maybe they were very sick with COVID and then they ended up in hospital and then they got some organ damage and now they've got some heart problems and lung problems and kidney problems. And that's sort of lumped in with long COVID. Then there's definitely this much bigger group of people who had kind of milder acute COVID symptoms, maybe weren't hospitalized, but then went on to develop the sort of classic ME picture. And then there's a third set of patients who just take a long, long time to get over COVID infection. So they may have symptoms at 3 months, but then they do just get better, but very, very slowly. And one of the challenges we have is we haven't really separated all of that out properly. And we still lump everything together, just like CFS has now been lumped in with ME. And I think that was a disaster for the ME community because anything can cause chronic fatigue. To be honest, you can work too hard and get chronic fatigue. You can have thyroid dysfunction, cancer, all of it causes chronic fatigue, but it's not the same as ME. And I think lumping CFS and ME together, which is what the psychiatrists did in the 70s, sort of downgraded it, and that's created a lot of problems. So we have to, through work like Professor Ponting's, we've got to define these illnesses much better and separate them out. A little bit like we have for autoimmune diseases. We don't just say autoimmune disease, we say, oh, it's rheumatoid arthritis or SLE or Sjögren's syndrome. We've defined all of those, and we're still right at the outset of that process, aren't we, Chris?
Thank you. And the question also was about genetics. Precision Life has already found that there is overlap in the genetics between ME and long COVID. And I'm not going to say anything more about that, but I won't be surprised if we also find genetic overlap between long COVID and ME, not just from the data that we're looking at, but for all the reasons that have been said.
What advice would you give to someone who, so my wife has been suffering from ME for a reasonably long time, and it's been sort of getting worse. She is in hospital now with quite sympathetic consultants and practitioners around her. My question is really, how can we sort of capitalize on the opportunity now that we have people listening and believing and keen to help? And they're also, I'll say that they're following the advice that she received from Dr. Weir a couple of weeks ago. So things like the B12 injections have started now, and they fully intend to take your advice and apply it. So is there anything before she's discharged that we should sort of make sure we don't leave without? And even in the bigger picture, convincing people who are listening to ask the right questions, that kind of thing. Just if any of the panel has anything to add to that.
Anyone whose illness has progressed to the point of requiring admission to hospital, I always advise intravenous fluid because it's 100% predictable that their circulating blood volume will be less than physiologically appropriate. And in my view, the first step towards any of the natural healing processes is to restore the blood volume to those people so that their tissues get a decent supply of oxygen for all the correct healing processes to start up. And in my view, the people who don't do well are the ones who are constantly run a low blood volume, and either because they can't drink enough to keep up with the reduction in blood volume, or they don't get the opportunity to get it intravenously. And I always tell hospital hospital doctors looking after such patients to make sure that their patients are properly hydrated, and the first step really is to employ intravenous infusion of normal saline.
So firstly, sorry to hear about your wife, but I'm pleased she's got some sympathetic doctors. That's hugely important. Agree with Willie. I think one of the main things that I see that is just left untreated for years and years and years is this dysautonomia. And it's because doctors get stuck on this idea that there's a distinct definition that you have to have your heart rate go up by 30 beats per minute every time you stand up to meet the diagnosis. But actually, it's a scale, it's a kind of spectrum. And so sometimes, a lot of the time, my patients won't necessarily hit that strict criteria, but you treat them anyway because their heart rate is inappropriately going up when they're doing anything. And that's exhausting. If you make somebody, it's like making someone sprint the whole time every time they do anything. So I quite aggressively treat tachycardia, basically. And but you have to move patients to diagnose it, or you have to monitor them over time to diagnose it. And generally, doctors don't get taught about this stuff. So if they haven't done a stand test to look at whether her heart rate's going up, make sure they do that. Make sure they're checking her blood pressure as well. But that's and replace the volume. Saline, salty water straight into the veins will make her feel much better, I'm sure. So those are some simple things that you might persuade them to do, and then control the heart rate.
My question is really around the comorbidities, with ME. And we, from the patient group, and I know from clinicians as well, there's a very much identification. We know about the MCAS, the POTS, connective tissues issues as well, and a lot of patients with Ehlers-Danlos syndrome. And genetically, I was just wondering, from perspective of responding, I'm sure that perspective is being examined, as well from the genetic point of view. And is there much linkage with other clinical or genetic groups to co-align or, check? I know the alliances are starting to get more structured. I know on the English side with the alliance between the different charities. And I was just wondering also, is that another way of maybe getting more momentum, making stronger alliances with different charities as well, with the comorbid groups, with people having multiple symptoms? Is that another way of just strengthening the position?
So definitely there are genetic correlations between ME and fibromyalgia and other overlapping conditions. I don't know that there is one for Ehlers-Danlos syndrome, to be honest, but for many others, dozens of them. Actually, I won't go more than that because it's unpublished. But however, a correlation does not mean cause here. So we need to dig deeper and find out what are not just the correlations, but the common causes. Personally, I think a lot of these conditions, maybe not EDS, but these are neuroimmune conditions. And their seat is going to be in the brain and perhaps in the brainstem as well. And these are the difficult places in the body to study, say the least. But modern science does fantastically well nowadays with difficulties, with challenging things to study. It does exceptionally well in those ways. And we have to push scientists to challenge themselves, to ask the question that you asked. Not just what is this disease, but what are these commonalities between diseases? And hold our feet to the fire as much as you can, because the tools exist. They just are not being applied.
This is a sort of anecdotal comment, but I actually have noticed quite a few patients presenting for the first time with all the clinical criteria for ME, chronic fatigue syndrome, and they're also hyperflexible. But then when you ask them, have you always been able to bend your thumb back like that? They will say no. And it occurs to me that there may be an acquired condition of ligamentous flexibility, which is secondary to this prolonged hypoxia due to this running a low blood volume all the time. And I think that, that is an entity.
I agree. I've got a number of patients who developed, maybe a little bit hypermobile beforehand, but certainly since COVID infection, their joints are literally falling out of their sockets, severe subluxations in some of them. So there's something very odd going on with connective tissue that we really don't understand at all. So
I just want to say thank you so much. That was so informative, and the first time that people have actually understood kind of what people on the outside are thinking. I have a daughter who has just gone through this process. I know I've spoke to Dr. Weir. She's 16, so she was running to All-Ireland level, very, very athletic, horse riding, footballing, and just one morning kind of just woke up feeling very unwell. My frustration is with A&E, which is maybe another area that may need to be, professionals in A&E maybe need to be educated. I had constant consultants just saying to me, I don't know what you want me to do. What do you actually want me to do with her? And us continuously going in and in and in, never admitted to hospital. She was in that age, 16 age, so she wasn't being seen by paediatrics. Then turned 17 in the middle of it, which was in a nightmare. So this constant battle. Kind of my question is, has there ever been anything flagged up as regard COVID vaccine linking into ME? It's a difficult one, because how can somebody be so unbelievably athletic and everything in life going quite good and brilliant and healthy, good food, good diet, and then just like bang. I get asked that question numerous times by people asking me, did you have the COVID vaccine? So it's just a food for thought.
I don't think it's controversial. I think there's definitely some patients who have had vaccine reactions. I see them in my clinic. I think they're the most stigmatized of all, because it's been politicized. And if you're going to give 1 billion of anything, you're going to get X percentage of side effects, and X percentage of 1 billion is a lot of people. So I think it's real. It's well described. There's actually quite a large number of publications about vaccine injury now. But what we haven't got is some really big, good quality, large peer-reviewed studies. So it's still in that kind of anecdotal kind of stage. But it is a possibility. I think, like all of these things, we don't have a diagnostic, so we don't know. So you're just guessing at the end of the day and trying to piece things together. And that makes it very difficult to persuade doctors that it is or it isn't, or get compensation. So it's a really challenging area, but I don't think it's that controversial because vaccine injuries have been described with every vaccine. Anyone else?
Can I just say that, again, anecdotally, and I don't think anyone's collected the statistics yet, but the two vaccines which do seem to play a very big part in this whole area are firstly hepatitis B vaccine and secondly the HPV vaccine that teenage girls get. I've seen a lot of that, and it's very worrying because one wants to do something about it, but at the moment there are no mechanisms with which to operate to do something about it.
Yeah, I even went as far as I've got a very severely injured, vaccine injured patient. He's very, very sick. It's ruined his whole life. I went as far as having a conversation with the head of vaccine safety, or whatever his title was, in AstraZeneca, because it was the AZ vaccine. And they're very much like, we acknowledge it happens, but it's kind of not our job to research it. Which it kind of isn't, actually. And so, but where are the big academic units that are going to invest in researching vaccine injury? So we end up in this situation where it's like nobody's problem, but everybody's problem. And yeah, that makes it really difficult. So they were like, well, we have the yellow card scheme. Okay. But yellow card is just about recording the side effects. It's not about investigating how or why. The only time they did investigate was when there were deaths and there was the blood clots on the brain. And then a lot of investment went into actually looking at the mechanisms. And then, of course, some countries stopped using AstraZeneca. But there isn't a mechanism by which chronic illness is investigated. And that is a problem with all of these things. And, you know, I'm not anti-vax. I think I've had 5 COVID vaccines, but you've got to acknowledge with every medicine there are side effects.
One thing I do remember as a schoolboy was before we used to queue up for vaccines then, and I remember queuing up for polio vaccine and being asked very carefully by the nurse who was administering the polio, did I feel okay and did I have a cold? And anyone who had a cold was actually not given the vaccine. And I think the principle that was being employed there was not to actually inflict more than one immunological stimulus at any one time. And I get the impression now that that's not happening. And multiple immunological stimuli have been shown with Gulf War syndrome to be very much predictive of the worst manifestations of Gulf War syndrome. The soldiers who got Gulf War syndrome the worst were the ones who had most vaccines in the shortest period of time. So the conclusion one can possibly draw is that multiple immunological stimuli are not particularly good for the body.